Look at this outcome. At 12 months, we have 92% survival of this group of 43 patients aged over 65 years old who had kidney transplants. That's really spectacular results that match the results in younger patients. We did have 3 early deaths in this group, one from a pulmonary embolus, one from a sudden death that wasn't explained, and one from from a high potassium, and here was the EKG that was really unacceptably high, but that is what actually happened. Cancers were, as you would expect, common among this group of older patients. 1 had had a breast cancer, 2 had had a cancer, and here it is, cancer in the kidney. Here's the native kidney with the little cancer seen there. 2 had had bladder cancer, 12% had had cancer of the prostate. Postoperatively, as expected, we also found cancers. Again, older patients will develop older kinds of diseases, and this is a picture of an infiltrating cancer of the bile ducts. Here's this infiltrating cholangiocarcinoma. And in kidney transplantation, different than some of the other kinds of organ transplantation, graft survival, or the kidney itself, may fall off without losing the patient, because if we can make a choice that we elect to lose the kidney without having the patient fail. That's different than if you have a heart transplant, because if you lose the heart, you also lose the patient. But in kidney transplantation, if we lose the kidney, of course, we can still continue to dialyze the patient. So as you would expect, as you might expect, in fact, over time, the graft will fail in some of these patients. But in fact, in this whole group, we really continue to do spectacularly well, again, at that 12-month point, really having excellent graft survival in this group as well. The typical kinds of technical problems that might happen in this post-transplant patient group, and this is one of those. It's called a lymphocele. Here's a CAT scan of a patient. Here's the kidney transplant that you can see. Here is the patient's bladder, and here is a fluid collection right here called a lymphocele squashing the patient's bladder, and this collection needed to be drained into the peritoneal cavity. And this frequency of 12% really is not elevated in this elderly group either, so that we didn't find in this elderly group an increased frequency of technical problems either. So I'm going to just skip through, because of the sake of time, to the heart complications. Again, I said that this was a fairly sick group of heart patients. Again, 16% had had coronary artery bypass before transplant. 14% had also had coronary artery stenting, pretty serious disease. Postoperatively, even, remember we had a 92% survival, but that included 3 patients who needed to have bypass grafting of the heart post-transplant. 2 needed aortic valve replacements. 1 needed a pacemaker postoperatively. I'm going to, just for the sake of time, keep moving along. Nevertheless, 92% survival at 1 year of this group. And remember, this was the row of celebrities who had had the transplants at the age of 65, only 1 of whom was alive. This is our Yale patient group, the top and bottom row. And look, they just all look pretty similar. So I think, in summary, with the older patients, what we can say is they do really well. So ethically, how can we possibly withhold transplants from them? It's a very difficult question. We can get them through the transplants with meticulous care and meticulous screening. So we've got a really bad problem. I don't know how I can withhold transplant from them. And in fact, across the United States, patients over 65 are the most rapidly growing group of transplant recipients. 720% growth, if you look at that, from 1989 to 2003. We're running out of organs, and one of the big reasons is because of the growth in this age group. Oh my goodness, what are we going to do? And in fact, in the 10th decade, what are we going to do? Do we transplant the patients or do we dialyze them? I don't have the right answers. And this is a problem that we as a society and as the medical people in society are going to have to help give guidance for, because there are no right answers. Unless we have more organs, we will not be able to solve this problem. I'm going to just skip through and make this point. James Michener, as you know, is a very famous author. He made he made the problem easy in his own case, because at the age of 90, when he had end-stage renal disease, he said he had had enough. He didn't seek a transplant. He withdrew from dialysis when he said he had written his last book, and he made the decision to die. But most patients don't make that decision, and they decide that they want to continue living, and we then have to make the decision how to take care of them. And the issue then becomes, in part, a cost-effectiveness question as well. And in fact, transplantation is more cost-effective for our society than dialytic care. In fact, after about 2 years, because transplantation in the first year is most costly because of the cost of an operation, being in the hospital in the first year. But after about 2 years, where the cost of medications is the principal cost, transplantation is less costly per year at about $10,000 per life year than dialysis that costs somewhere between $55,000 and $80,000 per life year. So I would put to the audience that perhaps, in fact, to lower cost for society, for geriatric patients, we should be considering transplantation as a preferential treatment. And I think in the interest of time, I'll stop there. Thank you very much.
Dr. Friedman presented the case for not abandoning the elderly patient. The second speaker, me, will perhaps puzzle and vex you with another case, and that is the case for marketing kidneys. Is this horrific, inflammatory, obnoxious, terrible? Or is it a reality that we have to face today? Under the banner of the ethical and legal concerns, we'll move on after me to Dr. Steinberg, who will consider what I and Amy have discussed, plus other matters that he feels are pertinent. The statistics are pretty clear. In 2002, and this USRDS stands for United States Renal Data System, there were 78,000 deaths, 431,000 Americans, and there weren't enough organs to go around. How to apply the organs that we have creates an incredible ethical stress. The first thing to realize, which you know anyhow, is that rich countries do better than poor countries in health and in kidney failure. On the left is the annual income of representative countries from the World Bank. Japan, $35,000 per person. Sierra Leone, Bangladesh, $84 a person. And the more money you make in a country per person, the longer the life expectancy. So no surprise, if you're a rich country, you live longer than if you're in a poor country. But note now what happens in terms of kidney failure. The rate, this is another sampling from the World Bank, and on the right, the percentage of patients who get treated, the number per million. If you're in a little country like Sierra Leone, where the income is virtually zilch, there are no transplants to speak of. The life expectancy is 45 years in Sierra Leone, and in the United States it's 77.4 years. The previous slide, which I gave you improperly, and I'm sorry, shows that the richer you are, the more kidney failure you treat in the number per million population. The poor countries treat almost nobody. The rich countries treat a lot of people. Now, in the